the intensity tends to plateau after 30 to 40 volts or 15 milliamps. The frequency has to be a high frequency for an autonomic function, low frequency for motor function. And this might be what happened with the abdominal program portion of the study. And then also above 50 hertz can cause complications. So something to be mindful of there. Pain reduction. So going back to my scoping review, there were positive results using a variety of settings. And these results were reduced frequency of pain, reduced severity of pain. There were 2 studies with mixed results. These are slightly older studies, but they actually stimulated incorrect areas. So they stimulated above the lesion. So since they did that, you wouldn't actually expect that there would be an effect on pain. So when we look to the other literature, the intensity, frequency, and pulse duration should be individualized to induce that paresthesia to prevent pain. And the frequency should be 50 to 150 hertz. Then moving on to lower extremity function, in my scoping review, there were mostly positive results. I will say that all the studies combined body weight supported treadmill training along with the lower extremity function. So what they found was, for example, the amount of body weight that they needed to support was actually reduced over time. They also found that different parameters of locomotion, for example, speed or endurance, also increased over time. And then with regard to standing, they found that individuals could stand with less support, and one individual could actually stand independently for, I think, about 45 seconds. There was one study that had negative results, but unfortunately it used that frequency that was too low to stimulate locomotor-like activity. And we'll talk about that a bit more in the next slide. So lower extremity function, they've researched this, I think, the most. I had the most studies in my scoping review on lower extremity function. And so they figured out the parameters a little bit more specifically. So they can tell you that the intensity, 4 volts, the tonic starts. With 5 volts, you're going to get potentially rhythmic locomotion. At 5.5, well-organized rhythmic locomotion. With the frequency, 2 hertz will evoke a monosynaptic reflex. 16 hertz will evoke consecutively generated reflexes. 22 to 50 hertz will evoke locomotor-like activity. And above 100 hertz, you'll get tonic motor output. So what happened in that Shapkova and Mushkin study was they used a pulse duration that was less than 500 microseconds, and supported by other literature, there was no obvious effect on locomotion. So they just didn't have enough stimulation there. And then unfortunately, there was only one study that looked at upper extremity function, but there were positive results. So this individual actually increased grip strength, so that's good. And the intensity they used was just a range to evoke minimal to peak motor response, so testing that. Then moving on to spasm reduction. So these were actually positive results. So I may have said actually in the overview that there were mixed results, but there were actually positive results for spasm and mixed for spasticity. So I want to clarify that. In the one study, there were a significant amount of complications using a broader range with a higher frequency. So basically in most studies, they reduced the severity and intensity and frequency of spasms. So for the settings from the literature, the intensity should be between sensory and motor, but sometimes below sensory. If it's too high, you can actually worsen the spasms. For frequency, it should be between 2 and 120 hertz, but again, not too high. And lastly, spasticity reduction. So in my scoping review, again, there were some positive and then some negative or mixed results. So the positive results basically eliminated or reduced spasticity enough so that an individual could walk just supported by crutches. And then negative or mixed results, they tended to use a low frequency range. And then one study also stimulated the anterior spinal cord and above the level of lesion. So again, that sort of incorrect stimulation site. Again, the frequency should be between 50 and 100 hertz for an optimal result in spasticity reduction. So now moving on to the discussion. So I'll talk a bit about the safety of epidural stimulation, the benefits, location, and then epidural stimulation, and then movement training. So first, for the safety of epidural stimulation, what we found throughout the studies is that now, through time, we've developed multi-contact electrode arrays with programmable devices. Again, these are a little bit safer, obviously easier and smaller to insert during surgery. Also, surgery has become minimally invasive, so shorter surgical times. Also, they become smaller microsurgeries. I did see a video actually the other week where the person said that it takes between, I think it took them between 1.5 and 2 hours to have their device inserted. Then moving on to surgical techniques and device construction. So again, we've refined surgical techniques over time and improved device construction. So what this has also led to is improved clinical results and also fewer and less severe adverse events. And now talking a bit about the benefits of epidural stimulation. So we talked a bit about the orthotic effects and therapeutic effects in the beginning. So using epidural stimulation to stimulate an orthotic effect, so at that single point in time, may actually lead to therapeutic effects. So in some of these studies, stimulation orthotically actually led to eliminating airway suctioning for a number of individuals. It eliminated spasms in some individuals, eliminated autonomic dysreflexia, and eliminated orthostatic hypotension in some individuals. But right now, they've tested an orthotic effect and they haven't seen a therapeutic effect on bladder function, sexual function, or standing ability. So perhaps it needs more research, or perhaps it doesn't have an effect. We don't know yet. Then also, epidural stimulation can be used to train other functional goals. So in the one study, it was used to suppress spasticity to walk, so that this individual could walk further with less support. It has also been used to suppress spasticity so that individuals could engage in voluntary motor movements. In another study, it was used to improve cardiorespiratory function, and that can help improve exercise. And of course, improving exercise can lead to different benefits. So improving muscle mass, retaining bone health, reducing other cardiovascular risk factors. So in the long run, this really may be beneficial. Maybe it can be used as an adjunct to medication. Maybe it can be used as an adjunct to surgeries, or maybe instead of, we don't know. Then also with regard to the location of the epidural stimulation device, we found that below the level of the lesion is most effective. So although there were some results when they were stimulated above the level of the lesion, if a result was going to occur, so for example, increased respiratory function, it would occur if you stimulated below the level lesion, and then sometimes if you stimulated above the level of the lesion. L2 was found to be the optimal site for locomotor function, so we know that, and that can be related to the studies on the central pattern generator in the lumbar spinal cord. And then also the best spot to stimulate someone would be in the posterior spinal cord, so in that epidural space in the dorsal roots for most functions. Okay, and lastly in our discussion, we're going to talk about epidural stimulation and movement training. So when individuals engaged in multimodal therapies or bodyweight support treadmill training, they had a high frequency of sessions, so up to maybe 3 times a week even, maybe plus home sessions they were doing on their own. A high number of sessions, so some totaled 80 or 120, so quite a number of sessions. These sessions were long in duration, so at least an hour, hour and a half in duration. So quite lengthy, quite a time commitment. So you can surmise that this might be difficult on maybe clinicians blocking out that time. It might be a lot for an individual with spinal cord injury to commit to and go to all the time. But when we looked at the research, we found that it was actually not identified as a barrier by individuals living with spinal cord injury when they talked about different barriers and facilitators. And then in fact, if we're looking at a different study, individuals with spinal cord injury consider a commitment to this type of therapy, this intensity, high frequency, and duration. They consider it part of a lifelong commitment. So positive results there. There were some limitations in my study. So for example, the terminology. So older studies just referred to spinal cord injury as complete or incomplete, and they didn't use the Aish scale. Also participants, there were some limitations there. So in one study, they included a couple of individuals with multiple sclerosis, and they didn't separate them from the results for individuals with spinal cord injury. Also, some participants were in the acute phase, so they may have had improvements because of the natural course of healing rather than epidural stimulation. We don't know. And then also I mentioned before the quality of the study. So we're looking at poor to fair quality studies. So really we do need to have more research in each of these areas, and we do need to produce higher quality studies. Some more future directions would be to continue with parameter testing. So you can see there's a lot out there, but we still need to refine it some more. And then also movement therapy combined with epidural stimulation. So again, using that epidural stimulation, having people engage in maybe locomotor training. And then we've also found that it can have some effects on, for example, bowel and bladder function, and just taking a look at those different effects that it might have on different systems. And then now for my conclusion. So my key takeaway statement is that the effects of epidural stimulation on most functional goals, particularly locomotion, show promise. And again, it's because that locomotion has the greater number of studies with a bit higher quality of evidence. Research and funders can target this area, so locomotion, and with continued positive results, they can move towards steps towards implementation and perhaps developing clinical guidelines. And I just wanted to acknowledge my supervisors, Dr. Kristen Musselman, also an author on this paper, Dr. Cesar Marquez Chin, and other authors on this paper, Dr. Cindy Gauthier, Dr. Kay Masani, and Maureen Prakash. And I always have the support of my SCI Mobility Lab members, so thank you very much to them. Also, I'm part of the Rehabilitation Sciences Institute at the University of Toronto, the SCI Mobility Lab, and the Kite Research Institute at University Health Network in Toronto. And I just wanted to mention again the podcast Spinal Moves. So we talk about activity-based therapy and Canadian perspectives. I just wanted to draw your attention to episode number 6, where I actually interview Dr. Andrei Krasyakov, the head of the American Spinal Injury Association, and he talks about epidural stimulation. Also on that same episode, so number 6, is transcutaneous stimulation with Dr. Sukhvinder Kelsey Ryan, and then a bit about the limitations like access to ABT, and that's by Dr. Adalberto Loyola Sanchez. And because Dr. Ho is with us today on episode 5, I actually interview him, and he talks a little bit, if you want to learn more about acute FES cycling and a few other pieces of technology. So that's available on Apple, iTunes, and also Spotify and wherever you want to get to podcasts, and it's free. And now, if anyone has any questions, go ahead. And this is, thank you very much for listening. And this is my contact information and the information about the manuscript and the abstract.
Hope, thank you very much for sharing your expertise, and thanks everyone for listening. I'm gonna stop the recording actually now and